Welcome to this Step 2 clinical knowledge review on medical complications in pregnancy test-taking strategies. This video is brought to you by Roadmap to Residency. We are going to break down the most common question patterns you will see on your board exam for diabetes, hypertension, thyroid disease, and venous thromboembolism in pregnancy. We will teach you strategies to pick the right answer quickly and confidently. Remember, the goal here is not to reteach the entire topic, but to help you recognize the patterns and apply test-taking strategies. Make sure you have reviewed the obstetrics and endocrinology sections of first aid and your question bank before or alongside this video. Here is what we are covering today. We will focus on 4 major medical complications in pregnancy: diabetes, hypertension, thyroid disease, and venous thromboembolism. For each one, we will go over the high-yield question stems you will encounter, the test-taking strategies to efficiently work through them, and practice questions with full answer walkthroughs. This is not a comprehensive lecture on these topics. You should review your first aid, your question bank, and your obstetrics resources for the foundational knowledge. This video is about strategy and pattern recognition on exam day. Let us start with our first strategy, which is distinguishing gestational diabetes from pre-gestational diabetes. This is a distinction the boards love to test. On the left, you see the gestational diabetes buzzwords. When you see a question about a patient being screened at 24 to 28 weeks with an abnormal glucose tolerance test, that is gestational diabetes. Diet and exercise come first, and insulin is added if glucose targets are not met. On the right, pre-gestational diabetes is when a patient enters pregnancy with an existing diabetes diagnosis. The key buzzwords here are an elevated hemoglobin A1C in the first trimester and congenital anomalies like neural tube defects and cardiac malformations. Pre-gestational diabetes carries higher risk because organogenesis happens early, so preconception counseling and glucose control are critical. When you see these buzzwords in a question stem, your job is to quickly categorize which type of diabetes the question is asking about because the management approach differs. Now let us talk about hypertensive disorders of pregnancy. This is one of the most heavily tested topics. On the left, gestational hypertension is new onset high blood pressure after 20 weeks without proteinuria or end organ damage. It resolves after delivery. Think of this as a diagnosis of exclusion. On the right, preeclampsia adds proteinuria or signs of end organ dysfunction like elevated liver enzymes, low platelets, kidney problems, or neurologic symptoms. Eclampsia means new onset seizures in this setting. The boards will present you with a clinical vignette and your job is to determine the severity. If you see severe features like very high blood pressure, headache, visual changes, or abnormal labs, that changes management completely. Magnesium sulfate for seizure prevention and delivery as definitive treatment are 2 board favorites. Now let us look at the classic question stems you will encounter. For gestational diabetes, look for the pregnant patient at 24 to 28 weeks with an abnormal glucose screen and risk factors like obesity or a prior large baby. The first step is always confirming with a glucose tolerance test. For preeclampsia, the classic stem is a pregnant patient after 20 weeks with new hypertension plus proteinuria, headache, visual changes, or right upper quadrant pain. Elevated liver enzymes and low platelets point towards severe disease. For thyroid disease, look for a pregnant patient with symptoms of either hyper or hypothyroidism. The boards want you to know that thyroid-stimulating hormone is the initial test. Propylthiouracil is preferred in the first trimester for hyperthyroidism, and levothyroxine is used for hypothyroidism. Recognizing these patterns in the first few seconds of reading a question will save you valuable time. Here is our first practice question. Read through this carefully. We have a 31-year-old woman at 26 weeks who failed her glucose challenge test, was confirmed with gestational diabetes on the 3-hour test, started diet changes, but after 2 weeks her fasting glucose is still elevated at 105. What do we do next? Take a moment and think about which answer you would choose before we walk through it. Let us walk through this answer together. Step 1. Spot the pattern. We have confirmed gestational diabetes, diet was attempted, and the fasting glucose is still above target. This is the classic failed lifestyle modification pattern. Step 2. Apply the board rule. When diet and exercise fail in gestational diabetes, insulin is the preferred next step. Insulin does not cross the placenta, which makes it safe for the fetus. This is a fundamental board principle. Step 3. Eliminate wrong answers. Answer A, Continuing diet when it has already failed is incorrect because 2 weeks of persistent hyperglycemia needs escalation. Answer B, metformin, is used in practice, but insulin remains the board-preferred answer for pregnancy. Answer D, delivery at 26 weeks, is dangerously premature and not indicated for glucose control. The correct answer is C, start insulin therapy. Here is our next practice question. This one tests preeclampsia management. We have a 34-year-old at 35 weeks with very high blood pressure, severe headache, right upper quadrant pain, low platelets, and elevated liver enzymes. What is the most appropriate next step? Think through your approach before we review the answer. Let us break this down. First, identify the severity. This patient has multiple severe features: blood pressure above 160/110, severe headache, right upper quadrant pain, thrombocytopenia, and elevated liver enzymes. This is severe preeclampsia, possibly evolving into a syndrome of hemolysis, elevated liver enzymes, and low platelets. Second, why delivery is the answer. At 35 weeks with severe features, the risks of continuing the pregnancy outweigh the benefits of fetal maturity. Delivery is the definitive treatment for preeclampsia. Magnesium sulfate is given to prevent seizures during the delivery process. Outpatient follow-up is never appropriate with severe features. Expectant management to 37 weeks is only considered in the absence of severe features and under very close monitoring. The correct answer is B, intravenous magnesium sulfate and delivery. Now let us review thyroid disease in pregnancy, which is a classic board topic. For hyperthyroidism, the key distinction is trimester-based drug choice. Propylthiouracil is used in the first trimester because methimazole can cause birth defects including aplasia cutis and chonal atresia. After the first trimester, you switch to methimazole because propylthiouracil carries a risk of liver damage. Radioactive iodine is absolutely contraindicated because it will destroy the fetal thyroid. For hypothyroidism, levothyroxine is the treatment, and the dose needs to be increased by about 30% as soon as pregnancy is confirmed. Untreated hypothyroidism has serious consequences, including impaired fetal brain development, preterm delivery, and even preeclampsia. Thyroid-stimulating hormone is monitored every trimester. Review your endocrinology resources for the specific target values in each trimester. Here is another practice question. We have a 29-year-old at 8 weeks gestation with a very low thyroid-stimulating hormone and an elevated free thyroxine. She has tremor, tachycardia, and weight loss. What is the best initial treatment? Pay close attention to the gestational age in this question, because it changes the answer. Let us walk through this. First, spot the classic pattern. This is first trimester hypothyroidism with suppressed thyroid-stimulating hormone, elevated free thyroxine, and classic symptoms. The gestational age of 8 weeks is the critical detail. Second, know the key distinction. In the first trimester, propylthiouracil is preferred over methimazole because methimazole is associated with teratogenic effects. Answer A, methimazole, is wrong because of teratogenicity in the first trimester. Answer C, radioactive iodine, is absolutely contraindicated in pregnancy as it crosses the placenta and destroys fetal thyroid. Answer D, levothyroxine, treats hypothyroidism, not hyperthyroidism. The correct answer is B, propylthiouracil. Let us finish with a test-taking pearl about venous thromboembolism in pregnancy. Pregnancy is a hypercoagulable state. The boards test this concept frequently. You need to know that pregnancy increases clotting factors, causes venous stasis from the growing uterus, and decreases protein S levels. When you see a pregnant patient with unilateral leg swelling, think deep vein thrombosis and order a compression ultrasound. For treatment, low molecular weight heparin is the anticoagulant of choice because warfarin crosses the placenta and causes serious birth defects, including nasal hyperplasia and stippled epiphyses. This is a very high-yield fact. Unfractionated heparin is used around the time of delivery because of its shorter half-life and the ability to reverse it quickly. If you remember nothing else from this section, remember that warfarin is contraindicated in pregnancy and heparin products are safe. That wraps up our review of medical complications in pregnancy test-taking strategies. To recap, we covered gestational versus pre-gestational diabetes management, hypertensive disorders, and the severity criteria that change management, thyroid medication safety by trimester, and anticoagulation principles in pregnancy. Go review the obstetrics and endocrinology chapters in first aid and work through related questions in your question bank. Focus on the management algorithms and the medication safety profiles we discussed today. For expert tutoring and residency advising, visit roadmaptoresidency.com. If this video helped you, please like and subscribe so we can keep making high-yield board review content for you. Good luck on your exam.